I'm about to share something that most doctors do not have time to explain during a standard appointment, and that the pharmaceutical industry has very little incentive to publicize. There are 5 categories of medications found in nearly every household in America, medications that millions of seniors take routinely and trust completely, that can quietly and progressively weaken the most important organ in your body, your heart. These are not experimental drugs or rare prescriptions. I'm talking about the pain reliever you reached for this morning, the stomach pill you swallowed with breakfast, the cold medicine you picked up at the pharmacy last week without a second thought. Medications that are marketed as safe, sold without restriction, and used so casually that most people never pause to consider what they might be doing to their cardiovascular system with every dose. I am Dr. Charles Anderson, and after years of working with seniors, I have watched patients walk through my door with hearts that were damaged not by disease, not by genetics, not by poor lifestyle choices, but by medications they trusted implicitly. And in too many cases, the connection between the medication and the cardiac damage was never identified until significant harm had already been done. By the end of this video, you will understand exactly which 5 medication categories pose the greatest hidden risk to your heart after 60, the specific mechanisms by which they cause damage, and most importantly, what you can do starting today to protect yourself. This is not about creating fear. This is about giving you the information you need to have a critically important conversation with your doctor that could add years of healthy function to your heart. Let me be absolutely clear about one thing before we begin. I am not telling you to stop taking any medication. Abruptly discontinuing prescribed medications can be extremely dangerous. What I am telling you is that you deserve to understand the full risk profile of what you are putting into your body. And you deserve a physician who is willing to regularly reassess whether each medication is still the best choice for your individual situation. Let us start with the medication category found in virtually every medicine cabinet in the country. Non-steroidal anti-inflammatory drugs, commonly known as NSAIDs. You know them by their brand names and generic identities. Ibuprofen, naproxen, diclofenac. They are the default solution for headaches, backaches, arthritis pain, menstrual cramps, and virtually every other form of common discomfort. They work brilliantly at reducing inflammation and pain. That much is undeniable. But here's what the label does not make sufficiently clear. Taking these medications regularly after 60, particularly if you have any existing cardiovascular concerns, creates a physiological environment inside your body that your heart was never designed to withstand over extended periods. The FDA recognized this danger as far back as 2005 and mandated stronger warnings about heart attack and stroke risk on NSAID packaging. Yet millions of people continue taking them daily, often for months or years at a stretch, completely unaware of the cumulative cardiac burden. Let me tell you about a patient I will call Arthur. Arthur was 72 years old, a dedicated gardener who spent hours in his yard every week tending to roses and vegetables. He had moderate knee arthritis and had been taking ibuprofen almost daily for over a year to manage the stiffness and discomfort that made kneeling difficult. One Saturday afternoon, while pruning his rose bushes, he felt an overwhelming fatigue sweep through his body. He could not catch his breath. His ankles, which he noticed had been slightly puffy for a few weeks, were now visibly swollen. When Arthur arrived at the emergency department, the diagnosis was acute heart failure. His heart, which had been dealing with the normal effects of aging and mild hypertension, had been pushed beyond its capacity. The trigger was not a new cardiac event. It was the cumulative effect of daily NSAID use, creating conditions his heart could no longer compensate for. The mechanism is insidious and operates on 2 fronts simultaneously. First, NSAIDs cause your body to retain sodium and water. They interfere with the kidney's ability to excrete these substances normally. The result is an increase in blood volume. Now, think about your heart as a pump. If the volume of fluid in the system it is pumping suddenly increases, that pump has to work harder with every beat. A young, elastic heart can absorb this extra workload. but a heart that has been beating for 70 years that may already be dealing with some degree of stiffness, some arterial narrowing, some blood pressure elevation. That heart is being asked to run at maximum capacity with no rest. Eventually, it cannot sustain the output and failure occurs. Second, NSAIDs constrict blood vessels throughout your body and can elevate blood pressure. Even in someone without a prior hypertension diagnosis, regular NSAID use can push blood pressure readings meaningfully higher. And for someone already taking blood pressure medication, NSAIDs can partially or completely neutralize the medication's effect. Your blood pressure rises. Your doctor sees the higher numbers, increases your dose, or adds another drug, and nobody identifies the NSAID as the underlying cause. The medication cascade we discussed in a previous video begins spinning. There is one more detail that most people do not know. If you take low-dose aspirin for heart protection, certain NSAIDs, particularly ibuprofen, can block aspirin's antiplatelet effect entirely when taken in close timing proximity. You believe you are protected. Your aspirin is sitting in your bloodstream doing nothing because the ibuprofen arrived first and occupied the receptor sites aspirin needs to function. What should you do? First, have an honest conversation with your doctor about your actual NSAID usage. Many people underreport how frequently they use these drugs because they are available over the counter and feel insignificant. Second, explore alternatives. Topical anti-inflammatory gels applied directly to the painful area deliver medication locally without the systemic cardiovascular effects. Acetaminophen, while not an anti-inflammatory, provides meaningful pain relief for many people with substantially less cardiac risk. Physical therapy, gentle exercise, and weight management can address the root cause of many pain conditions rather than masking the symptoms. And if an NSAID is genuinely necessary, the principle is lowest effective dose for the shortest possible duration, not as a daily supplement for chronic discomfort. The second medication category will surprise you because it is marketed specifically as a protector. I am talking about proton pump inhibitors, the stomach acid suppressors. Omeprazole, pantoprazole, lansoprazole. These are among the most widely prescribed medications on Earth. Millions of seniors take one every single morning, often indefinitely, for acid reflux or to protect their stomach lining from the effects of other medications, including the NSAIDs we just discussed. The irony of one heart-damaging medication being prescribed to counteract the stomach effects of another heart-damaging medication is not lost on me. Let me tell you about a patient named Evelyn. Evelyn was 68 and had been taking omeprazole for chronic reflux for nearly 5 years. Her acid symptoms had resolved completely, and she never questioned the ongoing prescription. During a routine evaluation, her electrocardiogram showed irregularities in her heart rhythm. Blood work revealed the cause. Her magnesium levels had dropped to dangerously low territory. Magnesium is the conductor of your heart's electrical orchestra. It maintains the precise timing and rhythm of every heartbeat. When magnesium is depleted, the orchestra loses its coordination. The heart begins producing irregular, potentially dangerous rhythms called arrhythmias. And chronic PPI use is one of the most common and most overlooked causes of magnesium depletion in older adults. These drugs suppress stomach acid, but adequate stomach acidity is essential for absorbing magnesium from your food. Suppress the acid long enough, and magnesium levels gradually decline until the heart's electrical system becomes unstable. But the concerns extend beyond magnesium. Multiple observational studies have identified an association between chronic PPI use and increased risk of heart attack. One proposed mechanism involves PPIs reducing nitric oxide availability in blood vessel walls. Nitric oxide is the molecule that keeps your arteries flexible and relaxed. When it is reduced, arteries stiffen, resistance increases, and the conditions for a cardiac event become more favorable. The exact causal pathway remains debated in the literature, but the statistical association is consistent enough to warrant serious consideration. Additionally, PPIs can interfere with clopidogrel, an antiplatelet medication prescribed after heart attacks and stent placements. The interference reduces clopidogrel's effectiveness, potentially leaving patients vulnerable to the very cardiac events the drug was prescribed to prevent. The fundamental problem is that PPIs were designed for short-term use, typically 4 to 8 weeks for acute conditions. They have instead become permanent prescriptions for problems that could often be managed through dietary modifications, eating smaller meals, avoiding late-night eating, reducing trigger foods, and elevating the head of the bed. If you have been taking a PPI for months or years, do not stop abruptly, as this can cause a rebound surge of acid production. Instead, talk to your doctor about a gradual tapering plan and explore whether lifestyle modifications can manage your symptoms without the medication. And if long-term use is medically necessary, insist that your magnesium levels be monitored regularly. The third medication category is one that almost every household possesses and that most people reach for without any hesitation whatsoever: oral decongestants for colds and sinus congestion. The active ingredients are typically pseudoephedrine or phenylephrine. They are available without prescription, they provide rapid relief from nasal stuffiness, and they are almost never discussed in the context of cardiac risk. For seniors over 60, that oversight is genuinely dangerous. I had a patient, a 74-year-old retired nurse named Patricia, who caught a severe head cold during winter. To breathe more comfortably, she purchased a well-known cold remedy containing pseudoephedrine. By the second day of use, she experienced palpitations so severe she felt her heart was trying to escape her chest. Intense dizziness. A splitting headache. Her daughter rushed her to the emergency room where her blood pressure was dangerously elevated and she had developed an irregular heart rhythm. The mechanism is straightforward. Pseudoephedrine and phenylephrine are vasoconstrictors. Their job is to narrow blood vessels. In your nasal passages, this shrinks swollen tissue and opens your airway. But the drug does not target your nose exclusively. It circulates throughout your entire body, constricting blood vessels everywhere. The consequences are twofold. First, widespread vasoconstriction forces your heart to pump against dramatically increased resistance. Imagine trying to push water through a hose that someone is squeezing. The pressure at the pump end skyrockets. For a senior whose cardiovascular system is already operating with reduced reserve, this pressure spike can be catastrophic. Second, these compounds are stimulants. They accelerate heart rate and can trigger irregular rhythms. In a heart that already has age-related electrical vulnerabilities, this additional stimulation can destabilize the system entirely. European regulatory agencies have recently issued renewed warnings about pseudoephedrine due to its association with rare but serious vascular events, including constriction of blood vessels supplying the brain. The critical danger is that these drugs require no prescription. People purchase them casually, take them without reading the warnings, and never consider the cardiac implications. If you are over 60, and especially if you have hypertension or any cardiac history, avoid oral decongestants entirely. Saline nasal sprays, steam inhalation, humidifiers, and nasal corticosteroid sprays that act locally without systemic effects are far safer alternatives that provide meaningful relief without threatening your heart. The fourth category addresses a class of medications still prescribed for both depression and chronic pain in older adults. Tricyclic antidepressants, including medications like amitriptyline and nortriptyline. Depression itself is a significant cardiovascular risk factor, so treating it is important. But the method of treatment matters enormously, and tricyclics carry cardiac risks that newer antidepressants do not. A patient I will call Raymond, 76 years old, had developed painful diabetic neuropathy in his feet. His doctor prescribed a low dose of amitriptyline, which is sometimes used off-label for nerve pain. The medication helped reduce the burning, but Raymond began experiencing dizziness every time he stood up from a seated position. One morning, he fainted in his bathroom and fractured his wrist catching himself on the sink. The cause was orthostatic hypotension, a sudden drop in blood pressure when transitioning from sitting or lying to standing. Tricyclics directly interfere with the body's ability to compensate for gravitational blood redistribution when you stand. For a senior, this effect dramatically increases fall risk, and falls in older adults frequently result in fractures, head injuries, and loss of independence. But the cardiac concerns extend beyond blood pressure drops. Tricyclics can accelerate resting heart rate, creating constant low-level stress on an aging heart. They can slow electrical conduction through the heart muscle, a change visible on electrocardiograms that increases the risk of serious ventricular arrhythmias. In susceptible individuals, these rhythm disturbances can cause sudden cardiac death. These risks are the reason tricyclics are no longer considered first-line treatment for depression in older adults. Newer classes of antidepressants offer substantially safer cardiac profiles. However, tricyclics are still prescribed, particularly for neuropathic pain. If you or someone you love takes one of these medications, ensure that blood pressure is being monitored in both sitting and standing positions, that regular electrocardiograms are performed, and that your doctor has considered whether safer alternatives have been adequately explored. The fifth and final category is perhaps the most controversial on this list, and it involves a supplement that millions of seniors take every day, believing they are protecting their bones. Calcium supplements. The message for decades was unambiguous. Take calcium for strong bones. Fight osteoporosis. Prevent fractures. And for many years, that advice went unquestioned. But a growing body of research is now raising serious concerns about the cardiovascular consequences of supplemental calcium, particularly in the high concentrated doses found in pills. Here is the distinction that matters. Calcium obtained from food sources, dairy products, leafy greens, sardines, fortified foods, does not appear to pose a cardiac risk. It is absorbed slowly, in modest amounts, and your body utilizes it efficiently. The concern arises specifically with supplemental calcium. When you swallow a calcium pill, it creates a rapid artificial spike of calcium concentration in your bloodstream. Your bones cannot absorb all of that calcium at once. The excess circulates through your vascular system, and there is evidence that it deposits in the walls of your arteries. This process, called arterial calcification, makes your arteries rigid and stiff. It contributes to the formation and hardening of the plaques that cause heart attacks. Several large studies have found a modest but statistically significant increase in heart attack risk among people taking calcium supplements compared to those who do not. Other studies have not confirmed this association, so the evidence remains debated. But the trend in the data is concerning enough that the conversation around calcium supplementation has shifted substantially in the medical community. The practical takeaway is straightforward. Prioritize getting your calcium from food whenever possible. If your doctor determines that supplementation is necessary based on bone density testing and fracture risk assessment, It should be a carefully considered medical decision that weighs bone health against cardiovascular risk, not something you initiate on your own because you saw an advertisement. And if you do supplement, never exceed the dose your physician recommends. More calcium does not equal stronger bones. It may simply mean more calcium ending up where it does not belong. Let me bring all of this together. We have discussed 5 medication categories: NSAIDs, proton pump inhibitors, oral decongestants, tricyclic antidepressants, and calcium supplements, each of which carries specific mechanisms by which it can damage or stress your heart, particularly in adults over 60. My message is not panic. My message is not to flush your medicine cabinet tonight. That would be dangerous and irresponsible. My message is empowerment. You now possess information that the majority of people never receive. You know that the arthritis pill can overload your heart with fluid. You know that the stomach protector can deplete the mineral that keeps your heart rhythm stable. You know that a simple cold remedy can spike your blood pressure to dangerous levels. You know that certain antidepressants can destabilize your heart's electrical system. And you know that the bone supplement can potentially harden your arteries. Use this knowledge to become a proactive, informed partner in your own healthcare. At your next appointment, bring a complete list of every medication and supplement you take, including over-the-counter products. Ask your doctor directly, given my age and my cardiac health, is each of these still the best option for me? Are there safer alternatives? Should we be monitoring anything specific? That conversation is the most important step you can take today to protect your heart for tomorrow. Every medication is a balance between benefit and risk, and that balance shifts as you age. Your heart has been working faithfully for you every second of your life. It has earned the most careful, thoughtful protection you can give it. There is one more thing I want to address before we close, and it is something I think about constantly when I talk with seniors about their medications. We live in a medical culture that is extraordinarily good at adding medications and remarkably reluctant to remove them. A drug gets prescribed for a valid reason at age 62. At age 72, that same drug is still on the list. Nobody has reassessed whether it is still necessary, whether the risk-benefit calculation has shifted with a decade of additional aging, whether the condition it was prescribed for has resolved or changed, or whether the drug is now interacting with 3 other medications that were added in the intervening years. This phenomenon has a name in geriatric medicine. It is called prescribing inertia, and it is one of the most pervasive problems in senior healthcare. Medications accumulate like sediment in a riverbed. Each one was placed there for a reason, but over time, the accumulation itself becomes the problem. The drug interactions multiply. The side effects compound. The nutritional depletions stack on top of each other. And the heart, which is dealing with all of these pharmacological forces simultaneously, while also managing the natural demands of aging, bears the greatest burden. If you are currently taking 5, 6, 7, or more daily medications, I would strongly encourage you to request what is called a comprehensive medication review. This can be performed by your primary care physician or, ideally, by a clinical pharmacist who specializes in geriatric polypharmacy. The goal is simple. Look at every single medication on the list and ask 3 questions about each one. Is this still necessary? Is there a safer alternative? Is this drug interacting with something else on the list in a way that creates risk? That single appointment, which takes perhaps 30 minutes, can sometimes result in the safe discontinuation of 1 or 2 medications that are no longer serving you. And the reduction in side effects, drug interactions, and cardiac burden that follows can be transformative. You are not just a collection of diagnoses that each require a separate pill. You are a whole person with a whole body. And that body functions best when the pharmacological load it carries is as lean and intentional as possible. Every medication should earn its place on your daily list by providing clear, current benefit that outweighs its specific risks for you at your current age. If it cannot meet that standard, it deserves to be questioned. If this information was valuable, share it with someone you care about. A parent, a spouse, a friend who takes one of these medications daily without questioning it. Leave a comment telling me which of these 5 categories surprised you most. I read every response. Subscribe to this channel for more honest, practical health conversations for adults over 60. I am Dr. Charles Anderson. Take care of yourself and take care of that heart. I will see you in the next video.